Dr. Eva Kabwongera Akiki. She's an immunisation specialist, team leader with UNICEF in Uganda. She has a master's in international medicine and a diploma in tropical medicine and public health, and has undertaken various postgraduate training courses. And these include health policy and financing at the London School of Tropical Medicine and Hygiene. Over 20 years of work experience in the area of public health, she's focused on immunisation, including polio eradication efforts. Since 2000, Dr. Eva has worked with UNICEF Uganda as an immunisation specialist. She's provided oversight, technical assistance, and she's ably contributed to ensuring immunisation coverage in Uganda. Prior to joining UNICEF, Dr. Eva served in the Ministry of Health Uganda, leading to polio national immunisation days and the Uganda National Expanded Program for Immunisation in UNIP. So I'd like to welcome Dr. Eva Kabwongera Akiki.
Thank you very much, Professor Murray, and thank you for the opportunity to make this presentation. I'm going to present about what makes immunization successful, and I will use Uganda as I will present the facts from Uganda. My presentation is going to look mainly at the key things that I think contribute to the good immunization program, and these include vaccine and logistics, advocacy and communication, service delivery, where we need to plan to reach every child, including the equity considerations, the urban immunization that is becoming an issue, using of the private sector, monitoring and surveillance is also very key, and then I end up with an immunization in the context of COVID. Resource mobilization and availability of funding is also a key issue. Supplementary immunization campaigns have also contributed to a successful immunization program. Uganda is found in East Africa, and it has a population of more than 40 million children, million population, a growth rate of 3%, and Uganda is one of the countries with the highest fertility rate, more than 5 births per woman. And yeah, it is divided into 235 districts and 1 capital city, though other capital cities are coming up. This slide just shows the immunization program, how it has been faring, the performance. We have more than 13 antigens that are given, but the slide shows that Uganda has been able to achieve at least the 80% mark for almost all the antigens, apart from some dips here and there. But the main problem is moving from 80 to 100%. It is something that always has a lot of issues. And here we also have the introduction of the new vaccines that has been coming on, starting in 2002 when we introduced the pentavalent vaccine, then 2014 PCV, IPV 2016, rotavirus 2018, and most recently we had MR that was introduced in the routine immunization program. The emergence of hesitancy is something that is coming up, and as I said, when you reach that level of 80% going on or upwards, always has a lot of issues. I'll start with the vaccine management and logistics, which is very key to our successful immunization program. Uganda has a very well-established central vaccine store, which is integrated with other medical supplies at national medical stores. According to the assessment by various teams in African region and even globally, it has been said to be the state-of-the-art medical stores that manages vaccines and is doing very, very, very well. And in every district, at least one thing that Uganda is proud of, we have the established district vaccine stores in almost all 135 districts. There are a few new ones that the system is not so well established, but at least in all the districts we have a district vaccine store. And then below the districts we have the health facilities, which we call static facilities that have the equipment, the cold chain equipment, to store vaccines, and these are more than 3,700. And these are well equipped, and the Gavi support that has come on has even improved the storage capacity much more, and this is very well established in all the districts. Human resource, of course, is very key to the immunization program, and with this related to vaccine management, we have the district at national level. We have the people who manage the vaccine at national level. At the district level, we have the district cold chain assistants, and then at the health facility level, we have the frontline health workers who also will manage the vaccine. Distribution of vaccines from national level, from Copenhagen to UNICEF, to at national level, is every quarter. The vaccines are brought in, and government of Uganda has been procuring most of the traditional vaccines, and the co-financing is so well done. So vaccine availability at national level is something that is well managed, and every month, National Medical Stores distributes vaccines to the districts. So it is very rare that we have stock out of vaccines at national level and even at the district vaccine stores. The problem sometimes is at the health facility level because of the last mile delivery, which is not so well established. So there is an issue. We have a lot of tools that help in the stock management. Of course, there are some issues with follow-up and making sure that everyone reports, but at least the system is there and well established. This slide just shows how the effective vaccine management assessments have been done over years from 2011 to 2018, and you can see the great improvement at the national level. The national level, that's why the last assessment that was done in 2018, it was reported as the state of the art vaccine management, and it is something that many people, many countries have come to learn and to know how the vaccines are well managed in Uganda. So at national level, it is quite very well done. The district level, it is also much improving, much better. The problem is at the health facility level, at the service delivery level, there are some issues, but these are also being addressed. So every time we do a vaccine management assessment, there is an implementation plan that is done to address some of the issues that have been, the gaps that have been identified. So there is a lot of improvement, but it is key to have a functioning vaccine management cold chain system to an effective immunization system. The next is the community mobilization. Community mobilization advocacy is key. And if you have the demand side well catered for, the supply side well catered for, you have to have the demand side also very well done. So in Uganda, one of the advantages that we have is at the highest level, immunization is a priority. So it is given the highest support that it actually requires. The president cannot talk for more than 5 minutes without mentioning immunization in almost every speech that he does. And he thinks it's very successful and he wants to maintain it successful. So there is always, the immunization program at least has that advantage. Commitment to co-financing, Uganda, at least we have been making sure that all the co-financing is paid. So there is nothing there's no defaulting, there's no anything. So that is the commitment at that level. Information dissemination through written and media platforms, communication, and mobilizing the communities. Immunization to be successful, the communities have to be aware. And we know that the dynamic population of the target population, because today I'm a mother, tomorrow I'm a grandmother, and the other day I'm completely off, and there's another cohort that is coming on. So that's the need of making sure that the information dissemination is constant, so that we have the population aware and they understand the value of immunization. So there are a lot of school programs also to make sure that the immunization should is taught right from the primary school, to make sure that people grow up with it, knowing that they have to immunize their children when they actually get them. The other mobilization is at the urban and the unreached populations and special groups. there's a lot of effort that is put in to make sure that all the populations are actually reached, going through their leaders, going through every effort that there is to make sure that the information actually reaches out. Village health teams, we have the village health teams that have been established. Every village has a team of community health workers that have been rated on the immunization program. They know the schedule, they know when a child is supposed to get what, how many doses, and these people have helped a lot moving from house to house. It is difficult to manage them during their routine immunization program, but at least this is one of the benefits of the supplementary immunization activities, because during that time there are adequate resources and the VHTs are sensitized more, and at least we ride on that. Whenever there is a campaign, the VHTs are given more information and they continue on until they, routine. Of course, the money is not there to sustain. They are working on, but at least is one of the channels that is used to mobilize the communities. Engagement of non-health stakeholders, especially through the churches, the kingdoms, using every opportunity that there is to make sure that the communities are mobilized. One thing that is coming up is now child registration, and this is something that needs to be done very well so that we are able to account for every child, so that when somebody is reporting, there's a child here by name, the father, the mother, and we can follow up, especially for default tracing, and be able to account for every child. So I think that's why the registration is coming on. Currently, we are using paper registration, but I think with time, an electronic registration system will be established. And if once this is done, then at least we'll be able to account for every child, so that even those who refuse, we can also still say that so-and-so has refused immunization, they reside in this place, and maybe if there's any effort to be done, one can go and look for those particular children that are refusing. So mobilization of the communities, community awareness is key for a very good immunization program. The planning, this slide mainly shows the planning that we need to know where the children who are not reached where they are, so that we are able to plan for them. This example is an equity assessment that was done in 2016 to identify the areas that have large numbers of unimmunized children and get the reasons why these children are actually not reached. So the map shows 36 districts, and these districts, if you remember the map that was shown earlier, the children who are not immunized, most of them are in the urban centers, in the districts hosting refugees. The reasons were actually found are the urban poor settlements, the migrant tribes, the ethnic minorities. There are some religious groups in some, especially in eastern part of Uganda, there are religious sects that refuse the immunization, the new settlements, the fishing communities. We have a lot of lakes in Uganda, so the fishing communities, because they are mobile, we find that some special effort has to be made to make sure that we reach the fishing communities. The refugee communities, also a lot of effort needs to be done and make sure that they are also reached. And the remote communities, there are some areas like there are 2 or 3 districts that are made up of islands. So going out to reach to those children, you have to make an extra effort to make sure that you reach, if you are to reach and every child. So we need to identify where they are and then plan to reach them and make sure that they are reached. And to sustain that program, it needs a lot of resources, as we shall see later. This is just the same map showing the unreached populations. And when you look at these 3 maps, you see that the urban areas, the areas with large numbers, the population are the areas that actually have large numbers of unimmunized children. That's why there's need for a special program to reach the urban unimmunized and actually plan for them properly. Here we gave an example of Kampala, Kampala State Council Authority. It is the capital city of Uganda, and we have had some extra effort that have been put in to make sure that we reduce the numbers of unimmunized children, and a lot of progress is done. One key thing about city authorities, you find that in Kampala, for example, only 16 health facilities are public and 172 are private. So dealing with the private facilities to make sure that they support the population is something that needs to be addressed when you are looking at urban populations. The VHT registration, you know, the VHTs in cities are not the same as the VHTs in communities. So there's a special effort and special energy that has to be put in to make sure that these VHTs actually do the work that they are supposed to do. And if you consider electronic registration, I think we shall start off with the urban populations. And also knowing that the urban populations are mobile, they move in and out, so it is very difficult to follow them. That's why you find that even in urban areas, the high dropout rates, because when somebody starts DPT1, maybe they move out to another area, so there's a very high dropout rate, which can be explained. So if you had a registered children, I think this would be able to follow up the children where they move to. Another key thing about immunization that we need, that is necessary, is monitoring and evaluation and surveillance to make sure that we know how we are moving, to make sure that every child is reached, to make sure that the health facilities that are doing the immunization, they actually tally and report regularly. So there has to be a system. In Uganda, we have the HMIS that is established well enough, at least to be able to pick out the data. And regularly there are EPI reviews and surveys that are done, and to make sure that we know where we are, and it helps in the planning. So monitoring and evaluation is key in the monitoring the immunization program. Of course, surveillance, looking for the diseases to be able to tell whether we are doing well or we are not doing well. In Kampala, for example, the measles outbreaks always start in Kampala State Council, though we have a very good coverage, usually more than 90% coverage rates, but the outbreaks usually start in the cities, and this is because of the very high population. Even if you reach 90%, there's always a very big population that build up, and in the end, we end up with an outbreak. So surveillance is also key to monitor and make sure that the immunization program is actually working. Just on the right here, we have the maps that show quarterly the analysis of the data that is available to make sure that we know which areas are performing well and those which are not doing well, and then plan accordingly. So monitoring is very important in a good immunization system. This slide is also some contributing factors to a very good immunization system. I will start with the supplemental immunization activities. This started in the mid-90s, and we have seen that the programs, the immunization campaigns, starting with polio, then we had the MNTE campaigns, then the measles campaigns, and then so many other campaigns, but they contribute greatly at least they've contributed greatly to the immunization program, because usually there are lots of funding that is available during the campaigns. It helps to micro-plan and mapping of the service delivery, getting people who are not usually reached during their routine immunization, and during this time when during the campaigns, if we identify such communities, it is much easier to follow them up after the campaign. So the supplementary immunization activities have contributed to this, identifying the unreached population, the unimmunized target population, the zero dose that we talk about in the polio campaigns and measles. It helps to know how somehow reaching out to these populations. And the campaigns have also contributed a lot to the building up, improving the capacity, storage capacity, because there are lots of funds that are available. Fridges have been bought, vaccine carriers, and all other tools. And the campaigns also provide an opportunity to train large numbers of health workers to make sure that they are on board. So it helps during those, we take usually that opportunity to add in so many other things on routine immunization when we are doing a campaign. Advocacy and awareness, of course, if we looked at data coverage around the time of the campaign, so immediately after there is a higher immunization coverage because of this heightened advocacy and awareness on immunization. So campaigns have contributed a lot to the immunization program. And one other main thing, and which is the most important for this, everything cannot be done unless we have the resources that we require. So immunization partnerships and resource mobilization and the people who contribute resources, I think is also very key. When, for example, Gavi started, if you look at when we started getting Gavi funding in 2002, the coverage was very low, but with time, it kept on increasing and increasing until we reached that level. And when the funds are out, you know, the coverage drops again. When they come in, then we rise up again. So funding is very key. And we have had so many different people contributing to this. And of course, the other partners working with them to make sure we do the planning, we support the Ministry of Health for them to be able to get where they're supposed to be is key. So partnership is a key thing for an immunization program. This is one of my last slides, is just look at the immunization and the COVID-19. And of course, because of the lockdown, because of the fear, because of the, you know, so many factors, the immunization program has slowed down. And as an example, I think an analysis was done January to April. There is that decline, especially between March and April, more than 17% coverage compared to 2019 data, DPT coverage. And this has had an impact on all the antigens. It is a big fear that if we don't do anything in this interim period, eventually we end up with measles and polio outbreaks, especially. So a lot of effort is being put in actually to make sure that the immunization program is back, at least on track. Communities are being mobilized. And we think that once we get some moderate PPEs for the health workers and the communities with some good mobilization, the immunization program is going to start. So a lot of effort is being put there to have the PPEs, both for the health workers and the communities, and then the community mobilization to tell them that there is that need for this continued immunization program. Otherwise, we end up with outbreaks if nothing is done immediately. This is just a summary slide in conclusion that it is important for a very successful immunization program. We have to have the vaccine supply quality to be able to have the potent vaccines delivered to the right eligible population at the right time and in the right doses and everything. Of course, logistics, I've talked about the logistics, the distribution need, and the last mile delivery still has a problem, but it is something that we need to do. Accessibility, to improve on accessibility. Service delivery is also another big area which has health workers and in so many other things, including micro planning to reach and to make sure that every child is actually identified, planned for, and reached. And if not reached, find out why and see how we can address those issues that are hindering that child to be immunized. Monitoring and surveillance is key. And of course, advocacy and communication to create demand for an immunization program. And then the supporting areas, the sustainable financing, management, strengthened human and institutional resources are all key to an immunization program. I'll just end here with some few pictures showing this is the most recent one of all these photographs. The most recent one in one of the remote districts in Uganda, where we have the hand washing as you come in, the social distancing you can see. And I think this time, this photo, when it was taken, the masks had not come on board so much. So, but if we get pictures now, we shall see a lot of masks. I think this is one of the other one where the health worker is putting on a mask. This is more in town than this one. And these are older pictures. I'll end with this slide, just showing how difficult the health workers, the difficulties they go through in reaching out. These are two teams. One team going for an outreach, just going into a small path, going out for an outreach somewhere in the communities. And then here, health workers, crossing waters, just walking in to go to make sure that they take services nearer to their communities. Thank you very much.